you so much for inviting me today. So my name is Dr. Lori Feldman-Winter. I'm a pediatrician here at Cooper Medical School of Rowan University in Camden, New Jersey, and delighted to be with you virtually in West Virginia. It would be great to be in West Virginia, I'm sure, right now as well. And today what I'm going to talk about is a complicated topic. The title of this talk is Breastfeeding and the Prevention of Sleep-Related Death. And sort of embedded in that, I'm going to talk a lot about bed sharing and physiologic sleep and present to you some of the protocols from the Academy of Breastfeeding Medicine. And so with that, here we go. In terms of disclosures, I have no significant financial disclosures and won't include any discussions of pharmaceuticals. I will mention, however, given my positions both within the board of the Academy of Breastfeeding Medicine and the protocols that I'll be presenting, and also previous positions I've held with the American Academy of Pediatrics and my Cooper position as well, that this presentation isn't meant to represent any of those organizations, and it's really a compilation of my own personal viewpoints, really synthesizing the evidence that has been presented previously. So what I hope to do is describe what is the normal mother-baby physiology as it relates to breastfeeding and sleep patterns, and delineate strategies to mitigate risk while protecting the normal physiology of sleep and breastfeeding. We're going to talk about how to promote and protect and support breastfeeding, and identify opportunities to message the prevention of sleep-related infant deaths, although we have to also acknowledge and recognize that we may not be able to completely prevent sleep-related infant deaths because we don't really have the kind of evidence in order to be able to do that. And we don't even really have a full understanding of causality in terms of what actually leads to sleep-related infant death. And we're going to speak about that in the setting of the breastfeeding population. I'm going to refer to two of our favorite clinical protocols that we've published from the Academy of Breastfeeding Medicine. The one on the left is protocol number 6, which is entitled Bed Sharing and Breastfeeding, the clinical protocol revision that was conducted in 2019, published in 2020. I should tell you that the protocol is currently under revision again because of a robust literature that has become available, and many of the authors that were part of this team the last time have reconvened. We have a lot of new authorship and a lot of new perspectives from other areas around the world. And we included, as I have in the title of this talk, this concept of the prevention of sleep-related death to the extent that we can. And so I'll be referring to aspects of the protocol, and I'll be showing you companion pieces, which is the handout that I think Dr. Katrina Mitchell mentioned in her talk last time, but the handout that accompanies this protocol, as well as the one on the right of this slide, which is a companion protocol to our bed sharing protocol, which is acknowledging and supporting physiologic infant care, which involves nighttime breastfeeding and normal sleep patterns. And this is a new protocol within the ABM called protocol number 37. And again, that has a companion patient family handout with some images and advice that, again, I'll be showing you throughout this presentation. So let's begin with West Virginia, where you guys are all located and working. I think there's a few things that are important to recognize. Number one is that the infant mortality rate in West Virginia is high. It's higher than the national rate, but it's declined. So something, and whatever it is that you are doing to decrease infant mortality in West Virginia has been borne out in that the rate has dropped from 7.2 per 1,000 live births to 5.6. Again, still a little higher than the national rate of 5.5. We must always recognize the tremendous disparities that exist. Black infant mortality rate is almost twice that of the non-Black. And so in West Virginia, it's 11.3 per 1,000 live births, whereas nationally it's 10.9. We also need to think about the other aspects of birth that may also be related to sleep-related deaths and infant mortality. Preterm birth, 13% of all live births in West Virginia are preemies. There's also a very high percent, almost 10% of live births are low birth weight, and about 18.5 births per 1,000 are to adolescents. Births to unmarried mothers, almost 50% of the births in West Virginia are to unmarried mothers, and the rate of cesarean delivery, which doesn't directly affect sleep-related deaths necessarily, but does definitely impact breastfeeding, is almost 35% of all births in West Virginia. So I think we have to have these figures kind of in the back of our mind when we think about the topics for today. In addition, West Virginia has the highest percent of adult smokers in the nation. And so nearly 1 in 5 adults are smoking, and smoking doesn't typically begin in adult years. I think what's even more striking here is that more than a quarter, 27% of high school students are using some form of tobacco. So certainly marketing, similar to commercial milk formula, the marketing of tobacco products is definitely aimed and targeted to our adolescent and even childhood populations. So that's an opportunity, both in terms of promoting breastfeeding, because again, that will help facilitate breastfeeding if we can decrease smoking, but also decrease infant mortality. And then finally, West Virginia has the lowest breastfeeding rate in the nation, according to the CDC data that was released in July of 2025. Nationally, almost shockingly, our national ever breastfeeding initiation rate is almost 86%, 85.7% of all births, whereas in West Virginia it's 71.7%, and breastfeeding to 6 months is 62% nationally and 46% in West Virginia. And then exclusive breastfeeding, which is really what's recommended, and the national priority for exclusive breastfeeding is for 6 months. Nationally, we're still only at 27.9%. Our national goal is above 44%. But in West Virginia, again, less than 1 in 5 West Virginians are exclusively breastfeeding according to national recommendations to 6 months. So why does this all matter? Well, first, smoking. It's a leading risk factor for infant mortality, including sudden unexpected infant death, or what I'll abbreviate as SUIDs, and SIDS, sudden infant death syndrome. Those are often sort of combined. SIDS is actually a component of SUIDs, which is more of an umbrella term according to the diagnostic criteria. Mothers who smoke are less likely to breastfeed, and they have lower milk volumes, and infants will take less milk while they're breastfeeding from a mother who's smoking. And then that's in contrast to the fact that breastfeeding is associated with the reduced risk of infant mortality, which I'll show you. And so we have to always think about the fact that breastfeeding does save lives. And this is a study that was conducted by Julie Ware and colleagues at the CDC, showing that breastfeeding initiation, so really just starting breastfeeding, doing any breastfeeding at birth, is associated with a decrease in postperinatal deaths. Postperinatal just means deaths after 7 days up to the first year of life. And it's associated with a reduction of 33% reduction in infant deaths. And for whatever reason, and I think we can only hypothesize as to why, that percent reduction is greater in the Mid-Atlantic region, as high as 44% reduction in the Mid-Atlantic region for whatever reason. And West Virginia, being part of that, has similarly a 37% reduction. So greater than the overall reduction just from breastfeeding at birth in terms of reducing that post-perinatal infant mortality. Now, when we look at breastfeeding continuation and specifically a reduced risk of sudden infant death syndrome, and this is a pooled analysis from 8 case-controlled studies, and the definitions here are important. There was no specificity in terms of breastfeeding, so other than breastfeeding at all versus exclusive breastfeeding. So that could mean direct breastfeeding, it could be feeding human milk, and the outcome measure was SIDS. So that's probably SIDS plus the other categories that fall under that umbrella, SUID. And what they showed was a 64% reduction from breastfeeding longer than 6 months. So continuing to breastfeed is associated with a tremendous decrease in the risk of SIDS. Interestingly, the AAP policy interpreted this study from Dr. Hawk, who was part of the task force, as the feeding of human milk, but I don't know that we could actually make that claim because the definitions weren't identified to that degree that we could actually say it's human milk is associated with decreased risk of SIDS versus breastfeeding. And I'm going to talk more about the importance of direct breastfeeding as well. So how can we do better and promote, protect, and support breastfeeding in the United States? And that's the subject of an entirely different talk that probably will last more than an hour. But I encourage all of you to access the recent NASM, or what stands for National Academies of Sciences, Engineering, and Medicine, what used to be called the Institute of Medicine, IOM. So we convened a committee to develop our national recommendations for breastfeeding. And this was just released last month and is available at the link at the bottom of this slide and articulates a whole host of different recommendations. The ones that I'm going to focus on today is about supporting the normal physiology of breastfeeding. And part of that normal physiology of breastfeeding is really understanding what's going on during the daytime and nighttime in the first few days in that mother-baby diet. And so what is that? What does it look like? Well, the normal infant sleep patterns are that babies are waking up throughout the night and feeding often, and that's normal. We know that there is melatonin in breast milk and that melatonin level fluctuates in a diurnal rhythm, and yet the diurnal rhythms that lead to babies sleeping more during the night and being awake more during the day really don't get established until the first few months after birth. So by about 12 to 16 weeks, those patterns begin to get established. So it's normal that babies are feeding often throughout the night. In fact, babies have to feed at night. They have to feed at night because they're growing. Their somatic growth is increasing tremendously, as well as their brain volume is increasing dramatically, exponentially in the first weeks to months after birth. And so they need to feed often in order to get the nutrients needed for that growth. In addition, mothers need to feed at night to maintain milk production, and also that frequency of feeding, not allowing too many hours to go between feedings so that prolactin continues to be stimulated, will help in terms of child spacing and what's called lactation amenorrhea method, which is those 3 criteria: less than 6 months, feeding often, not having long periods of hiatus between feeds, and being amenorrhea. So those 3 criteria, if met, can actually lead to child spacing and a prevention of conception that's similar to actually taking the oral contraceptive pill in women of childbearing age. So the normal physiology is described by some and first coined by James McKenna as breast sleeping. So breastfeeding mothers may be in the sideline position, may not be fully awake when they're actually breastfeeding, may wake up somewhat and be definitely more arousable, as are their babies, but they may not even be able to recall how many times they fed throughout the evening. And so that is anthropologically and culturally the norm. for breastfeeding mothers all around the world, except in the US, where the recommendation is to not share the same sleep surface or to denounce bed sharing because of the concern about risk for SUID. And those images were actually derived from the handout from protocol number 37, which I'll show you more later. So many wonder, well, does breastfeeding versus formula bottle feeding result in shorter amounts of maternal sleep? You know, is that going to keep the mom awake all night? And as I mentioned, sometimes moms don't even recall how many times she was feeding throughout the night. And these studies, there were several studies done by Doan and colleagues using an objective measure. So actually using wrist actigraphy, which objectively measures maternal sleep. Those who exclusively breastfed their 1 and 3 month olds actually slept longer than did their formula feeding or combination feeding counterparts. So in fact, breastfeeding, even beyond maternal recall, which as I said, may not be perfect if they're breast sleeping, using wrist actigraphy actually shows that moms are getting more sleep as long as they're together and exclusively breastfeeding. In addition, bed sharing is associated with an increased duration of any unexclusive breastfeeding, and I'm going to show you some of the evidence behind that. First, in the study that was published in JAMA, looking at the infant feeding practices study, which comes from the CDC, there was a protection of breastfeeding cessation for both any breastfeeding and exclusive breastfeeding. Mostly for, you can see the curve that differs is the one for often bed sharing. So there's a difference when they stratify by often bed sharing compared to moderate and rare bed sharing. So that matters. Those that are routinely bed sharing really have the greatest protection. And this was also demonstrated by Helen Ball's group, showing after a randomized controlled trial that was conducted in the hospital to look at breastfeeding as a result of using sidecar bassinets in the hospital. And I'm not going to share the results of that. There's actually been a lot of study in the US by Kristen Tully, who was at that time in 2016, a colleague of Helen Ball's in the UK, looking at sidecar bassinets to actually develop a better in-hospital bassinet. And most of what I'm talking about today is not about in-hospital recommendations. I think we have work to do, and Dr. Tully and colleagues at UNC are actually working on different ways to create an environment that's safe and supportive of breastfeeding while still in the hospital, really focused on the period once the mother baby died goes home. And so they did this randomized controlled trial and then followed those babies after they left the hospital up through 26 weeks. And again, used that survival of breastfeeding Kaplan-Meier method of survival analysis and showed that, again, the best protection for any exclusive breastfeeding was for those who often bed shared. So again, stratifying, there's a difference between those who routinely bed share versus those who are just doing it often, but not all the time. And what that difference is and why it matters, we're not 100% sure, but we have some theories that I'll talk about. So breast sleeping may actually be more protective, even though we think it's a risk factor for SUID. It may in some ways be protective against SUID. Bed sharing and breastfeeding infants are unlikely to be placed on pillows, which can be hazardous. Mothers are actually, mothers and babies are in more arousable states. So moms are very aware of their baby if they should show signs of distress. And infants will almost never sleep prone or even sleep on their side. They'll be on their side to feed, but then often roll on their back once they're done feeding. And so we'll be back to sleep. And we know that the back to sleep or supine sleep position is associated with a great reduction in risk of SIDS. So this is another illustration from Protocol 37's handout showing that mom can be in the same position and feed from either breast, and babies will learn to find the breast and attach and breastfeed again, sometimes with mom not even recognizing how many times that happened. Melissa Bartik has done a lot of work using epidemiologic large data sets, looking at breastfeeding, mostly breastfeeding initiation, but then also some looking at breastfeeding continuation. And in her work, she proposes this concept that bed sharing could actually be the confounder between breastfeeding exposure and sleep-related death as an outcome, meaning not all confounders interfere with the relationship. In this case, breastfeeding may partially explain the relationship between, bed sharing may partially explain the relationship between breastfeeding and sleep-related death. So it may actually be the bed sharing relationship in the breastfeeding, particularly exclusively breastfeeding, direct breastfeeding, mother-infant dyad, that explains that reduced risk of SIDS. And so thinking about that as part of the mechanism helps us push further to think about ways to research this interrelationship to have a better understanding of the best ways to prevent death. But we have to recognize that AAP and US HHS recommends against bed sharing. They recommend back to sleep, which is consistent with PBM and others. Sharing a room, which obviously you have to be sharing a room if you're bed sharing, but again, they don't recommend bed sharing. I'm using a firm mattress, but also using a separate sleep surface, such as a bassinet or a crib. And they do recommend breastfeeding, although, as I mentioned, the latest iteration of the AAP policy recommended human milk feeding, and I'm not so sure that that relationship exists, and not sure that the protections are conferred if the recommendation is for bottle feeding human milk. And I think it's important that we do recognize not only that that bed sharing is pathologized and stigmatized and very often taboo, that it may be normal physiology and it may actually be part of the mechanism for how breastfeeding is protective against SIDS. And it's hard to imagine for many people how to exclusively breastfeed and do it without bed sharing, because babies are feeding at night. And the other thing that I think it's important to acknowledge is that babies can indeed die. Bed sharing breastfeeding babies can die and do die in bed sharing arrangements. And we're not sure if there's other underlying factors that we're missing, not recognizing in that situation. We saw all kinds of things on social media, and it's, I would say, still going on. So here we are really promoting exclusive breastfeeding, but we recognize the fact that there's also very strong messages not to bed share, so to keep that baby in a separate crib. And for just practicality, the way this was interpreted in the culture was to hire night nurses for those that could do that and afford that, pumping and allowing the baby to feed human milk, again, with that promotion that human milk is going to prevent against SIDS, not recognizing that it might actually be bed sharing, that bed sharing and direct breastfeeding that might be preventative. And so the other thing that we hear about is the unfortunate situation where moms choose to breastfeed at night, but they do so in a chair or sofa to avoid the bed. And that carries a very high risk for falling asleep and having a baby die of suffocation or strangulation, so the other part of the SUID umbrella. So, so we're really setting families up for kind of exhausted moms, nightmare situations, and really undermining what we're trying to do, which is prevent sleep-related deaths and promote breastfeeding. I think it's interesting to recognize that doctors bed share too. We did a cross-sectional sample of doctors, over 500 doctors that were sampled to see what their practices were in terms of bed sharing, and 68% reported a history of bed sharing. These are doctors that either work as OB pediatricians or family medicine physicians, so really primarily in care and responsible for caring for pregnant women, pregnant people, and infants. But again, consistent with previous studies, those that bed share breastfed for 4 months or longer than those who never bed shared. So knowing that breastfeeding was still associated with increased duration of breastfeeding. And that the primary reason for bed sharing was, in fact, to breastfeed. And the primary reason for not bed sharing was the safety concerns, those things that are really heavily publicized here in the US. I think what's critical in this study is the fact that more than half of those surveyed that were bed sharing did not inform their child health care provider that they were doing it. And so we don't even know if they were asked, but they did not inform them. So their pediatric care providers or pediatricians had no idea that these babies were bed sharing. So they had no opportunity to even have a conversation about how to make it safer. So let's talk about the evidence for the AAP position to recommend against bed sharing. The evidence comes from first Feldman study that was done a while ago in 2012, looking at SIDS and the risk of bed sharing. This was a systematic review looking at 11 studies, and the summary odds was almost 2.9, so almost threefold increased risk of dying from bed sharing. But when she stratified those that were smoking versus non-smoking, the risk from the smoking population was very high, 6.27, and the risk of the non-smoking population was apparent. It was 1.66, so a 60% increased risk, but it was not statistically significant. So we can say that there was no statistical increased risk. And we'll come back to that because there's another figure I'm going to show you that's somewhat similar. In addition, when they stratified for usual bed sharing versus just bed sharing on that last night, again, I keep coming back to this concept of usual bed sharing being less hazardous than those that bed share just on occasion or just, when everybody's exhausted or inadvertently or in a way that's not predicted or expected or planned. Planning for bed sharing is safer than unplanned bed sharing. And so usual bed sharing in Feldman studies didn't show any increased risk. Carpenter study, which was really the primary study underpinning the AAP recommendations, again, is a systematic review of 19 studies. And these studies were done in the UK and Europe and Australia and Asia, where, as you can see on this graph, they looked at cases from birth to 50 weeks, and the peak distribution of cases in their sample had deaths that occurred between 7 and 10 weeks. We know, however, that the peak incidence in SIDS is 2 to 4 months, so later than what was apparent in their study. And the arrow that I point to here is that 16-week mark, which is important because they also looked at the adjusted odds ratio for bed sharing and stratified by smoking or not smoking. And you can see here that the line crosses, the confidence intervals cross 1 or the null at around 16 weeks. So the hazard is really for those babies under 16 weeks. And those lines continue to go down. So bed sharing may actually be, again, preventive, particularly for those babies older than 16 weeks. But in their summary, and again, after adjustment for risk factors such as smoking and alcohol, they came up with a summary odds of 5.1. So 5.1 times the risk of bed sharing versus not bed sharing in those babies that are under 16 weeks. But in that 5.1, they hadn't included breastfeeding. And so now adding breastfeeding to the equation and developing a summary risk ratio, the risk is 2.7 in those that are breastfeeding, bed sharing with no other risk factors. And this really equates to about 15 deaths per 100,000 infants. So not zero, still pretty low, but not zero. And we don't know, what is responsible for those 15 bed sharing deaths among breastfeeding, no other risk factor infants, whether there was prematurity or some other risk factor that might have been associated with those 15 deaths. It's interesting that Carpenter added to his discussion the fact that they recommend breastfeeding, again, as a protective factor for SIDS, and that the baby less than 4 months, or really according to their data, less than 16 weeks, which is about 3.5 months, be brought into bed for feeding at night, but then afterwards be placed on his back in his own crib. And that initially was part of the AAP recommendation, and they've kind of shortened or softened even that recommendation in terms of breastfeeding in bed at night, again, because of the worry that the mom is going to fall asleep. There are limitations in the Carpenter study. The control group was female, lowering the risk of SIDS, magnifying the risk of bed sharing. The study's old, hasn't been repeated, and it's not a US population. This study has always been compared to the study by Peter Blair, which was also a review that combined 2 different studies. And in Peter Blair's review, he looked at 400 cases and about 3 times the number of controls. And again, controlled for alcohol use and tobacco use, but because of the sample size was unable to do an adjusted odds ratio, so only actually presented an unadjusted odds ratio. And the finding was that bed sharing in the absence of these hazards produced an odds of 1.62. Again, similar, I think I showed you a while ago, similar to the Veneman study that had an odds of 1.66, and similarly crossed the null of 1, so was considered statistically not significant. But I would argue that it was probably a situation of too low of power sample size, and that these studies really need to be repeated with more power. And there are limitations of the Blair study. The control group included both room sharing and solitary sleep, increasing the risk of SUIDs in the controls, minimizing the risk difference. And parental drug use, even though alcohol and tobacco use was included in the study, parental drug use was not included in the analysis. It also should be noted that there's a significant protective factor for non-hazardous bread sharing in the older breastfeeding population. So it's okay to be on the fence, because I think that the evidence, is imperfect. The results of the BEST study is not available. The methods of study are not without their own limitations. Until we can collect the right data with the right population and the right variables, I think it's really hard to get off the fence. What we should recognize is that accidental suffocation death is rare among bed sharing, breastfeeding infants in the absence of other hazards. And I would just edit this, and I think we are going to edit this for the next edition. I would just say rare among bed sharing breastfeeding, like direct breastfeeding infants, because I think it's the feeding method of direct breastfeeding that really is part of the protective feature. We should be aware of and have opportunities to have conversations about the risk factors for bed sharing. And these are the lists drawn directly from Protocol 6. Again, I think there's room for improvement to reorganize this table to think about the conditions that are less modifiable, like the babies that were born premature or low birth weight. Those babies, even if they're directly exclusively breastfeeding, probably should be recommended not to bed share. Again, those who are impaired, adults who may be impaired by alcohol or drugs, even prescription drugs, should not be bed sharing. And then there's a variety of other environmental factors. And then I think it's important that we be clear that the recommendations around bed sharing, even though what we found is that many bed sharing situations occur in the non-breastfeeding, not even human milk feeding population. And so I think we have to be clear that the recommendations that we make in protocol number 6 is for the breastfeeding population. So, and I would probably say for the non-bottle feeding population. So for those directly breastfeeding, because we don't even know that bottle feeding human milk is necessarily protected. And what we have in the companion piece to protocol 6 is the handout that articulates both how to make the bed safer. Again, these are, and I would say safer, not necessarily safe, because we don't know how to completely prevent bed sharing hazards. But to have this conversation, the fact that these conversations aren't happening are part of the hazards. So using that firm flat mattress, moving the bed away from the wall, making sure that there's no spaces around the edge of the bed where the baby could become entrapped. So all these other environmental factors that could in fact lead to sleep-related deaths are important to discuss and plan for bed sharing. If we're promoting assisted breastfeeding, then planning for bed sharing if that's going to happen, if that's the intent, planning for it in a way that's safest. Again, knowing those that we wouldn't recommend bed sharing, so that list of who shouldn't be recommended to bed share, but then what to do if they're not recommended to bed share. So using a bassinet that allows the baby to be within arm's reach or approximate sleep. So that is what's articulated in protocol number 37, to breastfeed in approximate sleep environment. So that could be bed sharing, but that could also be in a bassinet next to the bed, again, within arm's reach. So moms can reach out and actually touch her baby. And that if a baby room sharing doesn't necessarily mean proximate sleep. We see that even in the hospital, we have rooming in and the baby's on one side of the room. And, mom would need to get out of bed to even get to her baby. So we see that room sharing doesn't beget that proximate sleep, which really does facilitate both breastfeeding as well as just touch and cuddling and having that human contact throughout the night. So proximate sleep can include breast sleeping, but also includes that baby within arm's reach. And using either a bedside bassinet or a sidecar bassinet is appropriate for that. And in a systematic review, looking at bed sharing, and again, looking at this question of, well, is that just going to, again, harm mother's sleep? What was shown in this study is that breastfeeding infants sleep well or better than formula feeding infants, and breastfeeding may be associated with better nighttime sleep postpartum for the mother. In this study that was done by Ian Paul and colleagues at Penn State, they were concerned about the AP recommendation for room sharing, not even talking about bed sharing, but just having the baby in the family parents' room. and that would decrease total sleep time. But the limitation of this study is that amount of total sleep time that was different between the non-room sharing and room sharing population could be accounted for just in the significant rates of nighttime infant feeding, which, as I showed you, is important for exclusive breastfeeding. So we know that exclusive breastfeeding babies are going to be feeding more often throughout the night, and that's physiologic and normal. And is consolidated sleep versus interrupted sleep even a good thing? And maybe consolidated sleep is one of the risk factors for sleep-related deaths. We know that when babies are by themselves in a separate room, they might have more consolidated sleep, but that carries a tenfold increase in risk of SUID and SIDS. So having babies, again, proximate to the mother, maybe even in the same bed, breastfeeding often, being at a sort of higher sleep state, more arousable, may be part of the mechanisms for prevention of SIDS and SUIDs. There was a number of other recommendations in Protocol 37 that I'm going to go through quickly just to sort of round out the whole picture of what this looks like. This is the handout that accompanies Protocol 37, and I've talked about most of these nighttime situations. I'll come back to a few of them, but in the daytime, keeping the baby in a bright, awake environment and really beginning to make that distinction between daytime, nighttime behaviors. So at night, not pumping and not bottle feeding and not doing really anything that's going to interfere with that normal sleep-wake breastfeeding cycle, even avoiding diaper changes. And most breastfeeding babies really don't need a burping session after breastfeeding is usually unnecessary. So just feeding, going back to sleep, feeding, going back to sleep is normal, keeping the room dark. If you're going to use a nightlight, it should be red, and other colored nightlights actually interfere with normal sleep patterns. There's a lot written about sleep training. And what we do know is that babies in the first 6 months don't actually really know how to be trained to sleep any better. They're not supposed to be trained. They don't really self-soothe. What they do is basically stop signaling their distress and stop crying and sort of become babies that aren't even particularly good at indicating feeding cues. And they have normally increased levels of cortisol, even if they're not crying. So they're stressed, even though you can't detect their stress if you measure their cortisol levels. Daytime recommendations are that the baby can be with the mom. You can use baby carriers, supervised tummy time. Getting help with household tasks is important for the mother to get some rest. And for infants over 6, keeping that baby really active during the daytime, and napping in a room that's not the crib and not completely dark is also important. Avoiding those baby tracking apps because the parents will watch the app instead of the baby, and that's not healthy for anybody. There is one study by Perkins et al. That showed if you gave babies solid food, that could actually increase sleep time. And it was a matter of 17 minutes increased sleep time. The problem is they never analyzed for the effects on solid food introduced before 6 months on weaning. So we don't recommend introducing solid food merely for the fact to increase sleep time. Again, we're not sure if consolidated sleep time is actually a good thing in terms of preventing sleep-related deaths. Once babies are separated from their moms because of either going back to work or for other reasons, I think it's important to have the conversations that babies will learn to do what we call reverse cycle feeding. So they're going to feed more often during the night because they're not around their moms during the daytime when they may be away at work or for what another reason. And so just anticipating that and bed sharing will definitely facilitate less fatigue and increased feeding regularity during the nighttime. And this is an interesting study by Pinestri, just reinforcing the fact that consolidated sleep for 6 or 8 hours at night is not normal. The majority of babies, and they looked at both breastfeeding and formula feeding babies, and the graphs that I'm showing you here is just for the breastfeeding dyads. And more often than not, those babies were not sleeping through the night, and that even more existed for babies as old as 12 months. And so babies having interrupted sleep to feed is normal and okay. And what's important is that these babies that were waking at night had no association with any mental, psychomotor, developmental problems, and it was not associated with a decline in maternal mood. And so what's important about that is that there's often the implication that mom's not sleeping at night is the thing that's undermining maternal mood. But in fact, what Thomas and speaker showed is that it was really the organization and regularity of the home environment that was most strongly related to maternal lack of maternal sleep disruption, fatigue, and depression. And so really having assistance in the home environment and focusing on the support system was more important than focusing on getting that baby to sleep for long consolidated sleep patterns. I do want to call out the fact that we have to recognize the increasing incidence of maternal mental health conditions that exist around the perinatal period. Screening is vital, and we should recognize the fact that consolidated sleep at night is part of the recommendations for mothers that are at risk for conditions such as bipolar disorder or other psychiatric conditions following delivery. In addition, mothers may be prescribed medications, psychotropic medications, and they may be sedating. And so for those situations, we wouldn't recommend bed sharing. And in some situations, we would not even recommend room sharing with the mother who has a condition of maternal mental health conditions. And this was the reference at the bottom here was a consensus panel by a panel of European doctors. The first author I've listed for you, Ricardo Davanzo, was not the second author, but I put him on here just to call out the fact that he's a widely recognized breastfeeding medicine advocate in Italy and was part of this panel. And I think more work needs to be done in this population, but I think the consensus panel recommendations are very helpful. And lastly, in this beautiful randomized controlled trial done by Mary Futrell, looking at cognitive behavioral therapy and relaxation techniques during pregnancy, they were actually able to demonstrate a difference, not only a difference in the mother, but also a difference in her milk and how that milk actually translated into babies that had increased feeding times, also different compositions of leptin and ghrelin, which resulted in better weight gain in the babies and actually longer infant sleep duration. And so can't hurt to think about part of prenatal care as involving CBT and relaxation techniques that can be helpful for breastfeeding mothers in the postpartum setting. So in conclusion, don't miss the opportunity to have conversations with families about their goals for breastfeeding as well as sleep, having conversations about safer sleep recommendations, which can include bed sharing, thinking about all the different conditions that would make bed sharing the least hazardous it can be. The conversation modules that were developed as part of the NABBLMC project funded by the CDC is at the bottom of this slide. That link helps different healthcare practitioners in all different domains of training, have conversations with families, having that list of bed sharing risk situations really at the forefront of your mind, knowing that those former preemies and low birth weight infants shouldn't be bed sharing. Those that were impacted by a smoke environment prenatally or postpartum shouldn't be bed sharing. Non-parents, and then other environmental situations. And any of the recommendations regarding bed sharing should only be thought about in the directly breastfeeding population, because we really don't know that any of the recommendations could apply to the even bottle feeding human milk population. And so we do encourage exclusive direct breastfeeding as the protective feeding method to prevent SIDS. So thank you so much for your time, and I will entertain any questions.
Thank you so much for
unmute
your time.
yourself.
Yeah. We had somebody write in the chat. Sorry, it's a little while ago. This is, I think the recommendations in the USA should be if there is an aide willing to support the process, etc. Dual of family member co-parents or wet nurse, then co-sleep can be safer.
So I'm not clear on the question.
It was just, I think, a comment about co-sleeping and making it safer.
Yeah, so I think that in order to make bed sharing, and I didn't talk about this, but there's often confusion around co-sleeping and bed sharing. Co-sleeping means sharing that sleep environment. Co-sleeping could include a baby that's proximate in a sidecar bassinet within arm's reach. That can be considered co-sleeping. And I would say is endorsed by the American Academy of Pediatrics. It's really bed sharing a sleep surface that is discouraged by the AAP and HHS. And so, I think that we still need to continue to ask the questions about whether the bed sharing breastfeeding population, direct breastfeeding population, no other risks, is actually a risk factor. We don't know everything that leads to sleep-related deaths. Again, I think that we forget that some babies die of SIDS because of congenital conditions or cardiac conditions such as channelopathies. And so it's really hard to dissect all the different reasons leading to SIDS. But we also recognize that there are babies that die in bed and they are directly breastfeeding.
Next, we have Anne, if you want to go ahead.
Mm-hmm. Yeah.
Hi, my first name is actually Anne Marie. Hi.
Oh, sorry.
That was great. No, that's okay. I loved your talk. That was great. I am in Indiana, actually, at the Indiana Department of Health, and I'm an IVCLC. And I struggle. I was wondering if you could speak a little bit about public health messaging. And, we adamantly have to publicize the ABCs of sleep versus what I know in practice to be different. I guess I need to be careful what I'm saying, but how do we coincide those, like the public health messaging with what the actual facts are and how we can really actually support families at night?
Hi, Anne-Marie. I appreciate your question because we're all on a fence and we're all challenged by what should be simple public health messaging. But by definition, public health messaging has to be simple, quick, like ABC, easy to say, easy to hear, and at a literacy level that is understood by all. The fact is that the ABC message is not received well by most, particularly most that have full intention to bed share, and by some who can't do anything but bed share. And so in that situation, if they have no access to a separate sleep surface or a bassinet that's bedside, the best we could do is to figure out ways to promote exclusive direct breastfeeding, and then to talk about how to keep the bed safer. And I would say that the conversation modules, which were funded by the US government, are the best way to think about having those conversations. So conversations between healthcare professionals and families in a setting that is supportive and allows families to be heard and safe and feel free to have open, honest, real conversations is the best way to be able to talk about all the nuances that are impossible to include in a public health message. And I think we have to just be honest about the fact that ABC as a public health message has not been successful. We have not seen a decrease in SUIDs as a result of the ABC messaging. NICHD, before it was unfortunately shut down by DOGE, I think was tiering that and actually doing a great job in creating some really nice images that were culturally diverse and showed breastfeeding in the bed in a handout that talked about safe sleep. We at the ABM have gone away from this term safe sleep because we don't really know how to make sleep completely safe, because we don't know, number one, the mechanisms behind sleep, all of sleep-related death, and we don't necessarily agree with the fact that bed sharing in and of itself can't be part of a safer sleep environment in the directly breastfeeding, exclusively breastfeeding population. And so, so I think that until we have really good evidence, it's hard to know how to construct a clear, simplistic public health message. So I would say that for the public health message now, what we should do is to say, breastfeed exclusively and talk to your healthcare professional about the safety of the sleep environment or safer sleep, to just encourage families to come to the table and have conversations, and not to try to tell them what to do in that public health message, but rather to encourage families that the what to do is to actually plan for what that sleep is going to look like at night and the realities of what exclusively breastfeeding mother-baby dyads look like, particularly in the first weeks and months after going home from the hospital, which is that they're going to be feeding throughout the night all the time, and often in bed. And in bed is preferable to in a couch or in a sofa. And so if you're feeding in a bed, the likelihood is that you'll probably fall asleep at some point. And so it's good to plan for that and to make the bed safer by doing the things that are in our handout.
Thank you. Yeah, I use your handout a lot. Actually, I like it a lot.
Thanks.
Thank you. We did have 2 comments. So the first one was from Susan. Would this be fair to tell a patient exclusive direct breastfeeding decreases SIDS and makes bed sharing safer?
So exclusive direct breastfeeding, I don't think itself makes bed sharing safer. It is associated with a decrease in SIDS, and that bed sharing in that population is probably part of that mechanism. So bed sharing in and of itself is probably part of the mechanism for how exclusive direct breastfeeding reduces SIDS. and breastfeeding will be facilitated, direct exclusive breastfeeding will be facilitated and
think, you
will
know,
happen for longer.
Taylor and
by
Molly
bed
covered,
sharing.
you know, what my comments would be.
Sorry, I know we're out of time. I'm just gonna read
Mhm.
through these last two.
Protocol, you know,
Mary
because we also.
Caldwell had said that she was a light sleeper, and she said, my personal experience and none of the list of risk factors. I breastfed 5 babies in bed shared for some of the night to nurse in. My bed was firm, had no puppy items. I often breastfed on the floor on a quilt like I was in a third world country, just wanting to be with family while watching a TV movie.
Okay, good point.
So
Yeah,
there's
I
that.
think we also have to call out the fact that the sleep
environment.
environment, the bed in and of itself, and the sleep environment looks very different around the world than it does in the US. Our beds are not even available in a lot of the countries that are now going to be participating, that have experts from those countries that are participating in the revision of our statement from ABM. And so I think, what we consider the ideal bed, in our country, in the US, is not necessarily even available, or the ideal bed around the world. And so we talk about a firm flat mattress. It's almost impossible if you go shop for a bed to find a firm flat mattress. Everything is so cushioned. And so the bed in and of itself might be the thing that's hazardous in our country because of just the culture of what people are buying in the market.
And then last question, it said feelings about the Safe Sleep 7 by, is it LLLI?
Yeah, I'll let you lead. Yeah. Right. So Linda Smith has been working on this issue of sleep and breastfeeding for a really long time. And I would say that much of what's in the Safe Sleep 7 is consistent and shared by what's in our clinical protocols from the ABM. I think short of some of the nuances that we're really trying to get at with some of the higher risk population. And so I think, unfortunately, we have to address high risk populations here in the US, which are increasing in incidence. And so we have to figure out other ways to support proximate sleep and direct breastfeeding.
All right, guys, so we're out of time, and I do apologize. Thank you. That was a lot of good conversation and questions for you. You put on a great presentation. Thank you so much for taking your time to present to our group today. Our next session, everyone, will be November 18th, and it will be What Do We Know About Tongue and Lip Ties by Dr. Kathy Leeper. So we will see everyone then. Thank you, everyone.
Take care.